My name is Mandeep Sawhney. I'm a gastroenterologist at the Beth Israel Deaconess Medical Center in Boston, and I've been asked to talk to you about quality measures in colonoscopy, what to measure and why it matters. So let's start with a 65-year-old woman who presents with excessive fatigue. She's found to have a hemoglobin of 5 and a very low ferritin. She's diagnosed with iron deficiency anemia. She's had a colonoscopy 3 years ago, which was reported as normal, and a repeat colonoscopy was recommended in 10 years. And you repeat this woman's colonoscopy, and unfortunately, what you see is a malignant appearing mass in the right colon. The colonoscope cannot traverse this lesion. This mass is biopsied, and the biopsies show adenocarcinoma of the colon. The preferred term for this lesion is post-colonoscopy colorectal cancer, and it's often abbreviated in the literature as PCCRC. And these are subdivided as interval cancers, which occur before the next recommended colonoscopy, or non-interval cancers that are diagnosed at or after the next colonoscopy. Now, most experts agree that a cancer that occurs 4 years after a colonoscopy is probably a new cancer and not related to failure of colonoscopy. So what do we know about post-colonoscopy colorectal cancers? In some series, they account for up to 10% of all colon cancers. They're more likely to occur in women, in patients who are older, and those who have diverticulosis, obviously associated with procedures that are incomplete or have poor bowel preparation. These seem to be biologically distinct in that they are more likely to be microsatellite unstable, and they also show hypermethylation and arise via the CIMP pathway. Most of these cancers are right-sided, and very pertinent to this talk is that they are often associated with certain endoscopist characteristics. So if the colonoscopy was done by a non-gastroenterologist, by an endoscopist who does a few colonoscopies, a low volume endoscopist, an endoscopist with a low cecal intubation rate, a low adenoma detection rate, and a very short withdrawal time, patients are more likely to develop post-colonoscopy colorectal cancers. If there's one thing you want to take from this presentation, it is that for every post-colonoscopy colorectal cancer, one should consider doing a root cause analysis. And I won't go over every steps in this algorithm other than to give you this consensus document reference. And what this does is this goes over how to determine the most plausible explanation for why your patient developed a colon cancer after a colonoscopy. And in the large-scale adjudication studies that have been done, the results are humbling in that almost 90% of these cancers are found to be avoidable. The most common cause of a post-colonoscopy colorectal cancer, and this accounts for almost 60% of such cancers, is that these lesions are probably missed due to an inadequate exam. Another fourth of these cancers, the lesions are probably missed even though the exam was adequate. And then a smaller subset of these cancers occur because a polyp was detected and for a variety of reasons was not removed or was incompletely removed, resulting in a cancer that developed later on. So coming to why measure quality, well, the first reason is to improve patient outcomes, and hopefully I've shown you with the last set of slides that we can continue to do better. But the second reason why quality measure is up in front is because of payment reform. And this is actually from an editorial written almost 2 decades ago by Bjorkman and Pop when they were presidents of the ASGE and the ACG, and they were predicting the future, suggesting that in the future reimbursement for endoscopy would be linked to reporting and performance on certain quality measures. But for those of us who are practicing today, we know that the future has been here for a while. So I think we all recognize the limitations of the fee-for-service model where reimbursement is based entirely on the quantity and volume of services provided. There's no reward for high-quality care. There's no penalty for poor or low-quality care. And all the risk, the excessive care that results from poor quality care is borne by the payer. So this is what's ushered in this new paradigm of value-based purchasing, where the idea is that you pay for value and not just for volume. Value in healthcare, and this is a definition worth knowing, is defined as healthcare outcomes per unit cost. And healthcare outcomes not only include clinical outcomes, but they also include a measure of safety and a measure of patient experience. So CMS's merit-based incentive payment system, or MIPS, is an example of a value-based purchasing model. You can see even in this model, the majority of reimbursement is based on the volume, but a small sliver is based on performance scores. And you can see that over time, the size of this sliver increases. And the other thing that I want to point out is that this model not only has carrots in that you can make a bonus if you meet those quality measures, but it also has sticks in that you actually lose money if you don't meet the quality measures. So the next question becomes, if we're going to base reimbursement on quality, can we even measure quality? Well, that answer was definitively answered by the Institutes of Medicine, where they said the quality of healthcare can be precisely defined and measured with the degree of scientific accuracy, which is comparable to most measures in medicine. And so the way we measure quality is with the use of quality indicators, and synonymous with that are quality measures or quality metrics. So quality indicators are surrogate markers for the quality of care. These are measurement tools that we use to guide and evaluate the quality of care that we provide to patients. Most quality indicators used in healthcare are ratio-based, and they're fairly straightforward. The numerator represents your performance. The denominator is the ideal performance, and then you can multiply that by 100 and convert it into a percentage. And you compare that to a benchmark or a target that is to be achieved. And we all are familiar with the cecal intubation rate, and we calculate that by the number of times we reach the cecum during colonoscopy. You divide that by the total number of colonoscopies that were performed, and then you compare that performance with a target or a benchmark, which in this case happens to be set at 95%. It's worth knowing that there are three types of quality indicators. The first type is structural quality indicators. These assess the infrastructure or the capacity to provide care. We're not going to discuss more of this because individual physicians don't have control over this. Or an example of this would be the percentage of endoscopy suites in your institution that have high definition endoscopes. We'll focus mostly on the next two types of quality indicators. Process quality indicators measure what a physician does for a patient and how well it's done. And then outcome quality indicators measure the outcome or the result of the care that was provided. So processes are a series of interrelated activities that are undertaken to achieve an objective. So the objective is to perform a colonoscopy, and then you can deconstruct that whole process into a series of processes. For example, process one would be you approach a patient and record a history and physical exam. Process number two is you document consent. And then you can take each process and assess that with a process-based quality indicator. So for example, you can compute in what percentage of cases was a history and physical exam recorded. And then you can compare that to an acceptable target, which in this case happens to be set at 95%. And this is heavily the focus of regulatory agencies like the Joint Commission. So when the inspector comes in and inspects your endoscopy suite, that's what they're doing. They have a series of process quality indicators. They have a benchmark for each of those quality indicators, and they're checking off whether your unit meets or does not meet that quality indicator. And these are key process quality indicators for colonoscopy. So how often in a colonoscopy report do you mention the quality of bowel preparation? And the benchmark for that is set at 98%, and you can read the rest of these. So outcome quality indicators look at the result or the effect of care provided, and these are of two kinds. The first is intermediate outcome quality indicators that measure changes in biological status that subsequently affect healthcare outcomes. Example would be blood pressure, which would subsequently affect the risk of having an MI. And then you have end outcome quality indicators that measure the clinically meaningful endpoint, for example, death from an MI. Now, in the ideal world, you would always measure the end outcome, but it's almost always exceedingly expensive to do so. You would have to follow a lot of patients for a very long period of time to measure this. And even if you were able to do that, this may not reflect physician performance, as these are often confounded by patient compliance and comorbidities. So in healthcare, most of the time, we're measuring either process quality indicators or an intermediate outcome indicator, because like we spoke about, these are readily measured, they directly reflect physician performance, and we have evidence-based benchmarks to define targets. Now, when we talk about an intermediate outcome quality indicator, it's very important that we talk about the validity of that intermediate outcome indicator, because we're not really measuring the outcome that we care about. We're measuring some intermediate outcome. So a valid quality indicator is one where we have strong evidence that improvement in that quality indicator corresponds consistently to improvement in a clinically meaningful endpoint. So let's talk about quality indicators for colonoscopy, and these are the 6 key quality indicators for colonoscopy. We're going to focus on the 3 that I've underlined, because for those 3, we have new information over the last couple of years. So the most important quality indicator in colonoscopy is the adenoma detection rate, which is defined as the proportion of colonoscopies at which at least one adenoma was detected. The population this is looked at is the asymptomatic average risk individual undergoing screening colonoscopy. This is an intermediate type outcome because we care about colon cancer, and a polyp is an intermediary in that sequence. And so the first question we're going to ask is the adenoma detection rate a valid quality indicator? In other words, does meeting this indicator result in better clinical outcomes that we really care about? So the first validation study was done by the Polish Colon Cancer Screening Group. This is a study published in the New England Journal of Medicine by Kaminsky and colleagues. 186 endoscopists who did over 45,000 screening colonoscopies. The outcome of the study was an interval colon cancer, which is a cancer diagnosed before the next scheduled colonoscopy. There were 42 interval cancers in this study, and you can see is that the endoscopist adenoma detection rate was strongly associated with the risk of an interval cancer. So in other words, if your colonoscopy was done by an endoscopist whose adenoma detection rate was over 20%, it was very unlikely that you would develop a colon cancer in the next 5 years. However, if your colonoscopy was done by an endoscopist whose adenoma detection rate was less than 20%, you can see there's many-fold more likely risk of developing a colon cancer. The second validation study is a larger study from the Kaiser Permanente group, over 300,000 colonoscopies performed by 136 gastroenterologists. One thing that's important to point out is that you can see there's a huge variation amongst endoscopists in their adenoma detection rate. And this has been shown in study after study. So you can see this ranges anywhere from 7% to 52%. So it's almost a 7 to 8 fold difference among endoscopists in their ability to find adenomas. So in this study, there were 716 interval colon cancers. And if you take endoscopists who are at the lowest quintile of the adenoma detection rate, 7% to 19%, and use them as the reference range, if a colonoscopy is done by an endoscopist with a higher adenoma detection rate, 19 to 23%, the risk of developing a subsequent colon cancer goes down by 7%. If the endoscopist has an adenoma detection rate of 23 to 28%, the risk of developing a colon cancer in the next 5 years goes down by 15%. And this graph does not plateau out till you get up to endoscopists who have an adenoma detection rate of at least 33%. So with this data, as you know, originally the minimum target for adenoma detection rate, or the minimum acceptable level for adenoma detection rate, was set at 20%. Then in 2015, it was increased to 25%. And in the most recent AGA update, the minimum standard is now 30%, with the expectation that most of us are going to try and aspire for an adenoma detection rate of at least 50% in our patients. A few comments on adenoma detection rate, because I've seen this show up on board questions. So currently, adenoma detection rate is not adjusted for race, for smoking, for obesity. Sessile serrated lesions are not counted in the numerator for adenoma detection rate because there's a lot of variability in how pathologists report these lesions. What procedures should we include in the denominator? Now, originally, the adenoma detection rate was described for patients undergoing their first screening colonoscopy, but now the denominator can be increased. So patients who are coming back for their 10-year follow-up colonoscopy, their adenoma detection rate is very similar to those patients having their first screening colonoscopy. Patients who have a history of polyp or cancers who are coming back for surveillance, their adenoma detection rate is only very slightly higher than this group. And then finally, patients who are undergoing diagnostic colonoscopy for rectal bleeding have a slightly lower adenoma detection rate. So the current recommendation is that we should include all these patients in the denominator because this is likely to average out. And what this allows you to do is use a much larger denominator, which will give you a more precise estimation of one's adenoma detection rate. What procedures should not be included in the adenoma detection rate calculation? Patients with polyposis syndrome, those patients undergoing colonoscopy for a positive FIT or a Cologuard test, and patients with inflammatory bowel disease. And presently, we also exclude patients who are undergoing screening colonoscopy who are between the ages of 45 and 50. In several studies, these patients have a slightly lower adenoma detection rate, 28% versus 36% for those who were 50 and above. So while adenoma detection rate is our most robust quality indicator, it's not without its limitations. And so one problem with adenoma detection rate is that it only gives you credit for the first polyp that you, or the first adenoma that you find in colonoscopy. And so some have suggested that we calculate this other quality indicator called the adenoma per colonoscopy, which gives you the average number of adenomas you find per colonoscopy. The other problem with the adenoma detection rate is that since our pathology reports don't talk to our endoscopy reports, the ADR has to be manually calculated. So a way around that is to maybe calculate a polyp detection rate, which is defined as the percentage of colonoscopies where you find at least one polyp as an alternative. Now, the reason why the adenoma detection rate remained king until now is because this was the only quality indicator for which we had validation studies. But that changed 2 years ago when the Polish screening group published their study in clinical gastroenterology and hepatology, and they looked at over 170,000 patients who were undergoing screening colonoscopy. And what they were able to do was validate the polyp detection rate and adenoma per colonoscopy rate. In other words, they found that an endoscopist polyp detection rate and an endoscopist adenoma per colonoscopy rate correlated strongly with the patient's risk of developing a subsequent interval cancer, suggesting that you could probably use either one of these three measures to calculate the quality of colonoscopy. And then interestingly, just this month, the New Hampshire Colonoscopy Registry published their study, and what they're suggesting is that maybe the adenoma per colonoscopy, which is the average number of adenomas per colonoscopy, may be better, maybe a more robust marker for quality of colonoscopy compared to the adenoma detection rate. And what they found was when they only looked at endoscopists who had an adenoma detection rate, the adenoma per colonoscopy rate still predicted who developed interval cancer, suggesting that this may be a more robust marker. We really need to see more studies before we, as a society, switch from adenoma detection rate to adenoma per colonoscopy rate as our preferred colonoscopy quality indicator. So if you look at colonoscopy quality indicators, you can almost think of them as a spectrum. So the closer you are to measuring the factor that you actually care about, post-colonoscopy cancers and you measure directly, the better assessment of quality you're going to have, but the more expensive it is going to be. For you to calculate a post-colonoscopy colorectal cancer rate, you have to follow every patient that you colonoscope for at least 10 years before you would come up with this rate. Obviously, something that's prohibitively expensive, but is the most accurate assessment of quality. And at the other end of the spectrum are process quality indicators, for example, where you're measuring the percentage of cases where you recorded a history and physical exam. They're obviously the easiest to measure, but they're the least direct assessment of quality. And somewhere in the middle is the sweet spot where you're looking at an intermediate outcome like an adenoma per colonoscopy or the adenoma detection rate, which is why these are so widely used. So one slide on evidence-based strategies to improve adenoma detection rates. So these are 3 strategies for which we have multiple randomized controlled trials that show that they improve adenoma detection rate. That's the use of artificial intelligence. That's the use of a cap at the end of a scope. The best data is on endocuff. And then looking twice in the right colon, either front view or with retroflexion. And remember, relatively small increases in adenoma detection rate. So a 1% increase in adenoma detection rate will result in a 3% reduction in the risk of post-colonoscopy colorectal cancer and a 5% reduction in the risk of death. So anything you can do to increase the adenoma detection rate will have huge or magnified outcomes. So let's switch gears and now talk about quality assessment in polypectomy. And the reason why this is important, we alluded to the beginning, is that we think that 8 to 15% of all interval cancers arise as a result of inadequate or incomplete polypectomy, leaving some tissue behind. And so how often is a polypectomy incomplete? This is a study of over 300 polypectomies where the endoscopist went and biopsied the base of the polyp after the polyp had been removed. And you can see that in almost 10% of cases after polypectomy, some adenoma was left behind. If you looked at polyps that were greater than 10 millimeters, in 17% of cases, some adenoma was left behind. And if you look at sessile serrated adenomas, which tend to be larger and more sessile, in almost 1/3 of the time, some adenoma tissue was left behind. And the other thing that you see in these studies, and again, this is replicated, is that there's a huge variation amongst gastroenterologists in their ability to remove polyps. And in this particular study, there was almost a 3.5-fold difference in being successfully able to remove a polyp. So assessing polypectomy quality is very difficult, and that's why you don't hear a lot about it. We have 2 validated tools that can be used for this. The first is the direct observation of polypectomy skills, and as the name implies, you have to directly observe or look at video recordings of polypectomy in order to make this assessment. And so what this tool does is it takes polypectomy and deconstructs it into its individual components, and it identifies 33 different components that an endoscopist typically does during a polypectomy. And then each of these components is scored on a scale of 1 to 4, and then these are added up at the end. So you can see this is a time-consuming or a cumbersome way of measuring quality. We also have another tool which is called the cold snare assessment polypectomy tool. It's a much shorter version of the above tool that I mentioned, but this looks at only cold snare resections. And in studies that have looked at the quality of colonoscopy, the results again are humbling. In this one study done from the UK, there was up to a 70% rate of suboptimal removal of polypectomy. The commonest errors that these authors reported were that endoscopists were incompletely assessing the polyp before resection, for example, failing to recognize that a polyp extends beyond a fold, a poor snare placement, and then not adequately resecting the margin after polypectomy were the commonest errors that were detected in this study. So an alternative way of looking at the quality of polypectomy that your endoscopy suite is providing is to look at these 3 factors that I mentioned. We know that large benign polyps should not be sent for surgical resection because several studies have shown that these patients do better with endoscopic resection. So one way to assess that is to see what percentage of large benign polyps was sent to an expert gastroenterologist and not to a surgeon. We can also look at how often a cold forceps was used to remove polyps, and we know that this should only be used to remove either 2 or 3 millimeter or less polyps. And then finally, we know that for polyps less than 10 millimeters in size, we should only be using a cold snare to remove these polyps. And another way to assess quality is to see what percentage of polyps less than 10% in your endoscopy suite were removed with a cold snare, not some other mechanism. So these are other ways of getting to the quality of colonoscopy, quality of polypectomy that you're providing. So let's now switch over to the third quality indicator, which is quality of bowel preparation. So the quality indicator here is to look at the percentage of colonoscopies that you perform for screening or surveillance where the bowel preparation is adequate so you can give these patients the recommended surveillance interval. In other words, you're not shortening the surveillance interval because of poor bowel preparation. And the benchmark, according to the ASGE for screening colonoscopies, is 85%. So more than 85% of all screening colonoscopies should have adequate bowel prep. And according to ESGE, that target should be upwards of 90%. You can also look at the quality of bowel preparation using certain process measures. So you can look at what percentage of patients that you're seeing were recommended a split dose bowel preparation. And we know that's the preferred way of giving bowel preparation. You can look at what percentage of patients that you're seeing where the second dose of bowel preparation began 4 to 6 hours before and was completed 2 hours before a colonoscopy. You can also look at how often you provided verbal and written instructions, and ideally the written instructions in the native language of the patient, because that too has been shown to improve overall colonoscopy preparation. And then finally, we have lots of data. We have multiple randomized trials that show that a low residue diet the day before colonoscopy is equivalent to a clear liquid diet with regard to the adequacy of bowel preparation and is much better tolerated. And so this would be another quality indicator that you may choose to use in your endoscopy suite, and that how often was a low residue diet and not a clear liquid diet recommended the day before colonoscopy, because that's better patient tolerated. So anytime you measure quality, there are bound to be certain pitfalls, and you can almost talk as much about the pitfalls of quality indicators as you can talk about the advantages of using quality indicators. And one example of this is Goodhart's law, which says that when a measure becomes a target, it ceases to be a good measure. And a great example of this is a wonderful editorial, which is titled "Hitting the Target but Missing the Point." So this is a study from the UK where the NHS instituted a quality indicator where they were going to measure how well an ER did by how often they were able to admit a patient within 4 hours of the patient walking into the ER. And so you can see the inadvertent consequences of this rule in that what ER started doing was they would refuse to let the ambulance drop the patient off to their ER until they were absolutely ready. So even though the idea of this quality indicator was to increase the efficiency by which patients were being treated, it had the opposite effect of patients spending more time in the ambulance because the ERs just wouldn't let them disembark because they were worried that they wouldn't be able to reach or meet this 4-hour goal. Another egregious example was some ERs would simply remove wheels from ER stretchers and call them hospital beds just so that they could show that from the time a patient arrived to the time they were admitted to the hospital, that happened within 4 hours. Another downside of quality indicators is the cost of reporting. This is a Johns Hopkins study that showed that in a 6-month period in 2029, they reported over 162 quality indicators at the cost of almost $6 million. And others have talked about how quality indicators reporting increases administrative burden, which in turn has been blamed for burnout and some consolidation in the small practices who are just not able to keep up with that. So in summary, we're seeing widespread use of quality indicators. Physicians are using quality indicators to identify gaps and areas of improvement Accrediting agencies like the Joint Commission are using it to document quality. Patients are increasingly using it to compare physicians and facilities, and I've shown you data that shows that payers are increasingly linking the reporting and meeting of quality indicators to reimbursement. Thank you very much for your attention.